Well, welcome everyone. I'm happy to be the first speaker on the agenda today, the first scientific speaker, talking about risk factors for pancreatic cancer. What we've heard is going to be the second most frequent cause of cancer death. Actually, it's going to be sooner than 2030. It'll be in now. I made the slide in December, but now that we're in the new year, it's going to be in probably estimated to be in 3 years from now rather than even than 4 years from now. Just to disclose conflicts of interest, I have some consulting activities. None of them are relevant for the talk today. This is a slide from the American Cancer Society Cancer Facts and Figures looking at age-adjusted death rates for males over the past 40 or 50 plus years. You can see that the big ticket items, the major causes of mortality have been coming down: lung cancer, prostate cancer, colorectal cancer. The pancreas down here has been inexorably trending just slightly upward. And the same thing is true for females, that the major causes have been going down. We've been doing a good job at reducing mortality from the major causes of cancer death, but we haven't done much for pancreatic cancer, and that's been increasing. Well, the projection for mortality over the next some years, this was from 2014, and these trends have continued. Yes, pancreas was going to be the second most frequent cause of cancer death in 2030, but it actually crosses colorectal cancer earlier, approximately 2021, 2022, which means that it's probably going to happen sooner, and we'll probably see it. It's already become third, and it's going to be second sooner than we realize. This pattern is not just in the United States. The same thing is seen in Germany. It's a little later, but they've also estimated the same pattern. So as of last year, pancreatic cancer is now the third most frequent cause of cancer death. There's more than 53,000 cases per year, and almost that number of deaths. Males and females are now affected almost the same. The incidence rates have been increasing about 1 to 1.5% per year. In general, there's a risk for any individual in the population of about 1.5% lifetime risk, which means by the time you turn 40, you'll have relatives, friends, acquaintances, you'll know people who've died of pancreatic cancer. The survival from this disease is dismal. The 1-year relative survival is in the order of 20 to 30%. There's some debate about 5-year relative survival. I think that on a population basis, it's around 3%. Selected studies of selected patients show that it might be as high as 8%, but when you look at a population basis, it's probably lower. And the only really effective treatment that we have is surgical resection, which only about a quarter of patients qualify for, and the resection only gives about 2 to 3 years of survival benefit, which isn't necessarily a lot and doesn't necessarily affect the overall course of the disease that would have progressed for another 2 or 3 years anyway. So what can we do for reducing the mortality from this disease? There's two approaches: primary prevention and secondary prevention. Primary prevention means preventing the disease from occurring in the first place, to identify modifiable risk factors, and then gain some population acceptance of changing those risk factors for the people to benefit. Secondly, we can identify or attempt to identify chemopreventive substances that will reduce the risk of pancreatic cancer. We have to find population subgroups where it's appropriate to use them, and then we have to get the people in those population subgroups willing to actually do it. Secondary prevention is a way of diagnosing pancreatic cancer early enough that our interventions can abort the fatal outcome, basically. And so in order to do this, we need to identify biomarkers or signs and symptoms of the disease early enough that it matters. And so in both cases, it isn't just a matter of finding biomarkers and other predictors of pancreatic cancer, but finding them early enough before diagnosis. And so we need to know the time course of the disease as well as just their relationship to the risk, to the disease. So what are we doing about identifying modifiable risk factors? American Cancer Society says that it has a list of a number of risk factors for pancreatic cancer, including cigarette smoking and other tobacco products. They've identified diabetes and obesity as a risk factor, high levels of alcohol consumption, and some minor, relatively minor on a population basis, factors associated with risk. They omit other factors that we've established. ABO blood group, non-O ABO blood group is a risk factor for pancreatic cancer. Jewish ethnicity, ancestry is a risk factor, and probably colonization by Helicobacter pylori is a risk factor, as we'll see. This is a kind of busy meta-analysis slide of more than 24 studies of ABO blood group and risk of pancreatic cancer going back into the 1960s. It's not something we invented recently. We've been looking at this for a long time. And on a population basis, we can estimate that non-O ABO blood group has a relative risk of about 1.4, which means because of its frequency in the population that it accounts for about 19% of cases of pancreatic cancer, which is entirely comparable to the effect of cigarette smoking. So between non-O ABO blood group and cigarette smoking, we've got 40% or close to 40% of the disease identified, although it's hard to do much about either. Okay, Jews have increased risk of pancreatic cancer, and basically we don't know why. This is a set of 3 sets of studies. The first ones are older studies of Jews born in Europe and coming to the United States. They've been found to have a relative risk of about 1.27, 1.3. More recent studies that mix Jews born outside of the U.S. with Jews born in the U.S. have a higher risk of 1.4, and the most recent studies of Jews born in the United States show a relative risk of about 1.5. So this is a trend that conflates where people were born with temporal patterns of increasing risk, and we'll see that we already know there's a temporal pattern of increasing risk for pancreatic cancer, and it's manifested here in Jews as well. Keep doing this. Helicobacter pylori is an interesting and complicated relationship to pancreatic cancer. Helicobacter pylori comes in 2 basic flavors: KAG positive organisms which suppress gastric acidity and are associated with decreased risk of pancreatic cancer, and KAG negative organisms which are associated with normal or increased gastric acidity and are associated with increased risk of pancreatic cancer. And this suggests that there may be a gastric acidity mechanism in how the pancreas is responding to the organism that predisposes it to modulating the risk from other carcinogens that the pancreas experiences based on exposures. So why should Jews be at higher risk? This is a perplexing issue because if one looks at the established risk factors for pancreatic cancer, they all go in the other direction, essentially all go in the other direction. This is a complicated slide that's kind of self-exploratory, and you'll look at it in the notes, but the take-home points here are that one would think that BRCA1 and 2 mutations, which are higher in Ashkenazi Jews, would increase their risk, but in fact, it only increases it about, we estimate, about 7%. That's not enough to matter why Jews should be at 40% increased risk or 50% increased risk. Non-O ABO blood group is irrelevant for this. Fewer Jews are current smokers. That would decrease risk. What the big issue here is education. And one can see comparing the education variables that, for example, looking at college and graduate schools, that Jews versus non-Jews are 20 years ahead in their degree of educational attainments, both males and females, this is an American Cancer Society cohort study and a case control study that I did in Connecticut. The same pattern is seen. Education is a protective risk factor for pancreatic cancer. Each of these categories here, of which there's 5, I guess, is associated with a 15% drop in risk, and Jews are ahead of this, but in fact they're at higher risk. So this is a perplexing issue, and it suggests that there's a genetic contribution that increases the risk of Jews. We've been studying that. We've done some genome-wide association studies in Jews and have not found anything yet. Interesting. What is apparent, though, is that Helicobacter pylori colonization is education related. People who have higher education, higher attained education, have on average higher socioeconomic status. The frequency of colonization of Helicobacter decreases with increasing education. And given that education has been increasing in American society over time, this decrease in colonization is thought to be related to a decreasing colonization of KAG positive Helicobacter. And if KAG positive Helicobacter reduces the risk of pancreatic cancer, which it seems to do, then decreasing colonization is going to give a trend over time of increasing the risk of the disease. And that's what we see. And so perhaps at least some of the trend in time that we see of increasing mortality and incidence of pancreatic cancer may be related to declining CAG-A-positive Helicobacter. And there's pros and cons of what to do about Helicobacter, and that's kind of, we could talk about it in a question session later. Okay, so what about chemopreventive substances? Here's what the ACS says about chemopreventive substances. Nothing. Now, there are the people have studied this. I mean, we're desperate to find chemopreventive substances, so there's been lots of studies, a few on each of many things. The ones that have had some consistent evidence are vitamin C intake and aspirin. This is a meta-analysis of vitamin C intake and risk of pancreatic cancer. The black squares are case control studies. The gray squares are cohort studies. What one sees is in the case control studies, a significantly decreased risk with intake of vitamin C related foods. The cohort studies, there's no association whatsoever. And it's hard to know whether this discrepancy is related to reverse causality, that people are changing their diets because of the disease, and by the time you interview them, they're not eating fruits and vegetables that have vitamin C in them, or because the cohort studies get dietary information at the baseline of follow-up and fairly infrequently thereafter, and so they may not have recent enough diet information during the period when it affects the risk of pancreatic cancer. Hard to know what's going on here. Aspirin is also interesting. There's now been quite a number of studies of aspirin intake and usage and risk of pancreatic cancer. There's been a trend in the magnitude of this association over time. So back in the 1970s and 80s, there was no association observed, but over time, there's been an average trend of a decreasing risk association, an inverse risk association with aspirin usage and pancreatic cancer, to the point that studies done recently on average predict about a third cut in risk with regular aspirin usage. This is for all aspirin usage, and here's for low-dose aspirin and risk of pancreatic cancer. It's the same thing, a relative risk and odds ratio of 0.68, so it's 2/3 the risk for people using low-dose aspirin. This is kind of a natural population experiment. People don't use aspirin, low-dose aspirin, for anything related that we know of related to pancreatic cancer, and so this is to some degree in causal reasoning an experimental study rather than an observational study, and therefore suggests that this trend may have some appreciable validity. What the mechanism of this is not really certain. Okay, what about biomarkers? We really want to find biomarkers to predict this disease early. Cancer Facts and Figures, the ACS says there's no reliable biomarkers available. They talk about CA19-9. We know that CA19-9 has been part of the Cancer-Seq panel, which came out a week or two ago, and I'll show you why that panel is unlikely to be useful for pancreatic cancer, unfortunately. The problem with pancreatic cancer is it's an infrequent disease. So I'm going to advocate not saying it's a rare disease, because if you say it's a rare disease, nobody will care about it. So I say we should call it an infrequent disease. The problem with infrequent diseases is that biomarkers that identify it need to have exquisite specificity. And the specificity here on the x-axis, you can see it's 0.98 at the far right here, going to greater than 99% in the left whole half of this. And these colors identify regions in the receiver operating curves, sensitivity versus specificity, ranges of the numbers of false positives for every true positive detected. And in order to get into this range here, the red range, of maybe an equal number of false positives for every true positive one detects, you need 99.9% specificity. The Cancer-Seq panel's got 99% specificity. It's over here, okay, in the yellow range. The yellow range is somewhere between 10 and 40 false positives for every true positive. How is that going to be useful in clinical life if the great majority of people you detect are false positives and you freak them out? Okay, so we have a very significant problem with biomarkers that for pancreatic cancer and its population frequency, we'd be better just telling everybody that they don't have it and they're not going to get it. Would be right 98.5% of the time. We've got to do a lot better than that. Okay, Here's a possible biomarker people have been thinking about, MUC5AC. It's expressed in pancreatic cancer, gastric cancer. That's okay if you're looking for diagnosis of pancreatic cancer, you're going to go by the stomach anyway, so if it's there instead, then you'll find that. The receiver operating curves for that marker are pretty good. They're in the range of 85 to 90%. That's getting there, but certainly not usable on its own. But we recognize we're going to have to put together a panel of markers like CancerSeq, but we're going to have to do better than the markers that are in CancerSeq. So this is promising, but still only a component of what we're going to end up using. Here's a marker that I've been looking at in my 2 case control studies, one in Shanghai, the other in Connecticut. Even for early stage disease, we're still getting approximately 90% area under the curve, so we're getting reasonably good sensitivity and specificity trade-offs in this. Again, this marker is not going to be standalone. It's in the range of here. By itself, it's in this range of contributing to a panel of biomarkers, but not an adequate biomarker by itself. All right, another thing we can do with pancreatic cancer is that it manifests itself before it's diagnosed. It generates signs and symptoms that are potentially usable just like biomarkers. Cancer Facts and Figures, the ACS says weight loss, diabetes, jaundice, various other signs and symptoms are manifest. Can we use those? Can we leverage those? Well, many of them occur too close to diagnosis to matter much. But in fact, some of them don't. And there are others that they neglected to mention, including heartburn, generation of episodes of pancreatitis, and changes in taste perception are also potential early manifestations. This is a plot of various studies that have looked at the risk of pancreatic cancer following a diagnosis of diabetes. And one can see that there, as we'll hear in more detail later, that in the early years after a diagnosis of diabetes, the risk of pancreatic cancer is at least 4-fold, if not higher. But as soon as you get a few years out, that ends up being, in long term, a risk of about 1.5. So diabetes is both a risk factor in the long term for pancreatic cancer and a prodrome announcement that pancreatic cancer is developing in the short term, and perhaps we can leverage that. This is the same plot looking at just the data from my Connecticut study. It shows a relative risk of about 5 going down over time. Well, there are other things that pancreatic cancer manifests. Quitting smoking occurs more frequently in people about to be diagnosed with pancreatic cancer. Probably they're just not feeling their normal selves. They're kind of, nauseous a little bit. It makes it easier for them to quit, something they've always wanted to do, and now they can do it because they're just not up to feeling, as good as they've been. And in fact, there's a risk of 3 to 4-fold for quitting smoking among smokers. There's pancreatitis is also a big announcement that pancreatic cancer may be occurring. The risks are at least 15-fold, maybe bigger, but within 2 years, that risk is essentially gone. If you survive 2 years after pancreatitis, it's not because it was pancreatic cancer that was manifesting it. Another factor is usage of proton pump inhibitor medications. That also, in some cases, is an announcement that pancreatic cancer is developing. There's a relative risk of 5 to 8-fold or something like that. And that also has a time course where by 5 years it's cut down appreciably. So to some degree, early pancreatic cancer is manifest this way. One can take these 4 factors that I've been discussing, put them together in a panel, and be able to predict pancreatic cancer to a certain degree, not as much as a biomarker say, but perhaps along with biomarkers, this could be used. This is a non-invasive, non-laboratory, something that people can evaluate for themselves, basically. They know whether they've been using PPIs and whether they've been diagnosed with diabetes and so on. So what we know is that cigarette smoking accounts for 20% of the disease. If people quit by age 40, their risk is basically baseline by age 60 when it matters. Obesity and diabetes still contribute to risk. We have to deal with that. For chemoprevention, aspirin use, including low-dose aspirin, probably cuts risk of the disease by at least 1/3. Maybe half the population has some indication for use of aspirin, and so there's some potential benefit in that people are not going to use aspirin for pancreatic cancer because the side effects of aspirin probably outweigh the risk of pancreatic cancer itself because it's still infrequent. PPI use is something that we need to explore more, whether it would do the same thing that KAG positive Helicobacter does in suppressing gastric acidity, and whether that would decrease the risk over long term. It needs to be studied. There's no data on that, and we should look at it. And whether vitamin C is a real association or artifactual needs to be identified. Early detection is something that everybody is trying to deal with. As I've said, these 4 factors, quitting smoking, symptomatic PPI use, diagnosis of pancreatitis, is a set of factors that, if they're temporally related, if 2 or more of them occur in temporal proximity, that's something to start thinking about as substantially increasing the risk that there's an underlying pancreatic cancer that could be diagnosed. This gets you about 2 to 3 years of possible lead time over the diagnosis, but that's, even resection, surgical resection that you could do for that isn't necessarily going to get you more than 2 to 3 years of survival. So whether this is going to be a beneficial trade-off needs to be determined empirically. And we want to add molecular markers to these kinds of signs and symptoms to try to get better lead time. So, as I've said, we're approaching this point when pancreatic cancer is going to be number 2 for mortality in the US. The number 1 is lung cancer, which is a man-made disease, and we know how to deal with that if we could. Pancreatic cancer, we don't know how to deal with, and as I said, we shouldn't call it rare, we should call it infrequent. So thank you for your attention. This was a cover on molecular carcinogenesis that we did some years ago, a whole issue devoted to pancreatic cancer, and these are people that you could recognize, all of whom died of pancreatic cancer. So thanks very much.